Hello, in this video I will discuss about postpartum hemorrhage. Postpartum hemorrhage is one of the serious and life-threatening obstetric emergency worldwide. It remains a leading cause of maternal morbidity and the mortality, especially in low-resource settings. Despite advance in obstetric care, rapid blood loss after delivery can deteriorate a patient's condition within a minute. Postpartum hemorrhage is defined as blood loss of more than 500 ml after vaginal delivery, blood loss of more than 1000 ml after cesarean section, or any amount of blood loss that result in hemodynamic instability. However, it is important to understand the visual estimation of blood loss is often inaccurate. Therefore, clinical signs such as tachycardia, hypotension, pallor, restlessness, and reduced urine output are equally important in diagnosis. Postpartum hemorrhage is classified into primary postpartum hemorrhage and the secondary postpartum hemorrhage. Primary postpartum hemorrhage occurring within the first 24 hours after delivery, and the secondary postpartum hemorrhage that is occurring from 24 hours up to 6 weeks postpartum. The most common cause is uterine atony, accounting for approximately 70 to 80% of cases. Early recognition, prompt resuscitation, identification of the underlying cause, and stepwise management are crucial to preventing maternal death. This presentation will focus on systemic guideline-based management of postpartum hemorrhage. Now I will discuss the causes of postpartum hemorrhage in a structured and the systemic manner. The causes of postpartum hemorrhage are remembered by the 4 T's: tone, trauma, tissue, and thrombin. The first cause is the tone. Decreased tone lead to uterine atony, the most common cause for the postpartum hemorrhage, accounting for approximately 70 to 80% of the cases. Normally, after delivery of the placenta, the uterus contracts to compress the blood vessels at the placental site. If the uterus fails to contract effectively, excessive bleeding occurs. Risk factors include over-distended uterus such as multiple pregnancy or polyhydramnios, prolonged labor, grand multiparity, use of tocolytics, chorioamnionitis. Uterine atony should always be considered first. The second cause, trauma, genital tract injury. If the uterus is well contracted but bleeding continues, trauma must be suspected. Causes include cervical tear, vaginal lacerations, perineal tear, episiotomy, extension, uterine rupture, inversion of the uterus. Careful inspection of the birth canal is essential in these cases. Third cause, tissue retained products of conception. Retained placenta or retained product of conception can be prevent effective uterine contractions and lead to persistent bleeding. Causes include retained placental fragments, placenta accreta spectrum, incomplete placental separation. Examination of the placenta after delivery is important to ensure completeness. Fourth cause is thrombin coagulation disorder. Coagulation abnormalities may either pre-exist or develop during pregnancy. Examples include disseminated intravascular coagulation, severe preeclampsia or HELP syndrome, placental abruption, inherited bleeding disorder. In such cases, the bleeding may occur despite a well-contracted uterus. Management of postpartum hemorrhage must be rapid, structured, and simultaneous. Resuscitation and identification of the cause should occur together. Step 1. Call for the help. Immediately recognize postpartum hemorrhage and activate the obstetric emergency protocol. Call senior obstetrician, inform anesthetist, alert blood bank, assign clear team role. Early team coordination is life-saving. Step 2. Immediate resuscitation through ABC approach. Airway and breathing. Ensure airways patent. Administer high flow oxygen 10 to 15 liters per minute. Circulation. Insert 2 large bore IV cannulas 14 to 16 gauge. Start rapid IV crystalloids. Monitor pulse, blood pressure, oxygen saturation, and send blood for hemoglobin, blood group, cross match, coagulation profile. Insert urinary catheter to monitor urine output. Step 3. Identify the cause from 4 T's. Simultaneously assess for tone, any uterine atony, trauma, genital tract tears, tissue, any retained placenta or product of conception, thrombin, coagulation disorder. Management must be cause specific. Step 4. Management of uterine atony. If uterus is soft and boggy, perform immediate uterine massage. Ensure bladder is empty. Administer oxytocin 10 international unit IM or IV infusion if bleeding persists. Ergometrin 0.2 mg IM or IV. Avoid in hypertension. Carboprost 250 microgram IM every 15 minutes up to 8 doses. Avoiding asthma. Misoprostol 800 to 1000 microgram per rectal or sublingual. Step 5. Tranexamic acid. Give 1 gram IV as early as possible. Repeat second dose if bleeding continues. This significantly reduces mortality from hemorrhage. Step 6. Mechanical measures. If medical therapy fails, bimanual uterine compression and uterine balloon tamponade are the option. These methods help compress bleeding vessels. Step 7. Surgical management. If bleeding persists despite conservative measures, then apply uterine compression sutures, uterine artery ligation, internal iliac artery ligation. Last resort, emergency peripartum hysterectomy. This is a life-saving procedure and should not be delayed in severe cases. Step 8. Blood and component therapy. Initiate massive transfusion protocol if required. Pack red blood cells, fresh frozen plasma, platelets, correct hypovolemia and coagulopathy promptly. Postpartum hemorrhage is a life-threatening obstetric emergency and one of the leading causes of maternal mortality worldwide. The most common cause is uterine atony, where the uterus fails to contract effectively after delivery, leading to continuous bleeding from the placental bed. Initial management of postpartum hemorrhage always begins with rapid resuscitation, uterine massage, administration of uterotonics, and tranexamic acid. However, when bleeding persists despite optimal medical therapy, the next crucial step is mechanical control of bleeding. At this stage, uterine balloon tamponade plays a vital role. Why balloon tamponade is important in PPH? Balloon tamponade works on a simple but powerful principle. It applies direct pressure inside the uterine cavity, compressing the bleeding vessels and promoting hemostasis. It is considered a fertility preserving procedure, minimally invasive, highly effective, a bridge between medical and surgical management. Early use of balloon tamponade can prevent the need for hysterectomy. Now, stepwise emphasis on balloon tamponade. What is the indication of balloon tamponade? Balloon tamponade is indicated when uterine atony persists after uterotonics. Bleeding continues despite medical management. Patient is stable enough for conservative intervention. It should be considered early before massive deteriorations. Step 2. Preparation of tamponade. Continuous resuscitation. Maintain IV access and monitoring. Catheterize bladder. Maintain aseptic precautions. Device use include bakery balloon, condom catheter in low resource setting. Then how a balloon tamponade inserted. Insert balloon into uterine cavity via cervix. Ensure correct placement. In C-section, insertion can be done directly through uterine incision. Then gradually inflate with normal saline, usually 300 to 500 ml. Inflate until bleeding reduces significantly. The goal is internal compression of uterine walls. Observe vaginal bleeding, monitor vital sign, continuous uterotonics. If bleeding stops, tamponade is successful. If bleeding persists, escalate immediately to surgical management. Balloon tamponade is extremely valuable because it is simple and quick. It can be performed in emergency setting. It reduces maternal mortality. It decreases the need for hysterectomy. It is especially life-saving in low-resource areas. It acts as critical step between medical therapy and the major surgery. Thank you for your kind attention. Postpartum hemorrhage remains one of the most critical obstetric emergency requiring rapid recognition, structure management and coordinated teamwork. Early identification of the cause, prompt resuscitation and timely stepwise interventions are essential to saving maternal lives. Among the available interventions, uterine balloon tamponade play a crucial role as a simple, effective, and fertility-preserving techniques that bridge the gap between medical and surgical management. With proper training and adherence to guidelines, maternal morbidity and mortality due to postpartum hemorrhage can be significantly reduced. Thank you once again. I welcome any question or discussion.